In this video lecture, we'll be talking about the basic management of anaphylactic shock. But just before we get into that, let's try to understand what anaphylactic shock is and how a patient would present. So an anaphylactic or an immediate hypersensitivity reaction is a type 1 reaction, which develops in people who are genetically susceptible and is mediated by the allergen-specific IgE antibody. When our body creates IgE antibodies, they bind onto the Fc receptors on mast cells, and then on subsequent re-exposure to an allergen, the allergen will bind onto the IgE, which is bound onto the mast cell, and therefore cause degranulation of the mast cell and release of many cytokines and many molecules such as histamine and echinoceuroids. Histamine will cause vasodilation, bronchoconstriction, and increased vascular permeability. And echinoceuroids such as leukotrienes and prostaglandins, as we've mentioned and seen before, will lead to inflammation, bronchoconstriction, and increased vascular permeability. How does a person with anaphylactic shock present? Well, 5 to 60 minutes after exposure to an allergen, they'll get hives, they'll get tissue edema or swelling. They'll also experience bronchospasm, which will cause them to wheeze. They'll become hypotensive, and this could eventually lead to cardiovascular collapse. They can also have some vomiting or diarrhea. Anaphylactic shock is a medical emergency, and the first-line treatment is absolutely critical. And in this case, the first-line treatment is usually not administered by a healthcare provider, but rather by the person themselves. I'm sure you've heard about people carrying an EpiPen around, and the reason why they carry an EpiPen around is because when anaphylactic shock suddenly arises, it's really important to treat it right away, or else it could be deadly. And the first-line treatment is epinephrine, and epinephrine works by stimulating 3 different types of adrenal receptors. It stimulates alpha receptors, which are found in the blood vessel walls, and they lead to vasoconstriction, and therefore by vasoconstricting the blood vessels we will drive blood pressure up, and this will help with hypotension and cardiovascular collapse, as well as angioedema. Epinephrine will also stimulate beta-1 adrenal receptors, which will increase cardiac contractility, and that's also important to drive blood pressure up and to make sure that there is no cardiovascular collapse. Epinephrine will finally stimulate beta-2 adrenal receptors, which are located in the lungs, and will lead to bronchodilation, which will help with the wheezing. Epinephrine is life-saving. However, it is crucially important that it is not administered within the artery. Epinephrine causes vasoconstriction, and if you administer it into an artery, that will vasoconstrict the artery, and that could lead to tissue necrosis. There is no absolute contraindication, so if a patient is suffering from anaphylactic shock, they should just administer it right away, and it needs to be administered rapidly, intramuscularly, usually into the thigh. And as I said, the device is an EpiPen or Anapen device, and there are many other companies that make them. Once a patient arrives to hospital, you can administer them antihistamines. As I said, IgE are on mast cells, and when an allergen binds onto them, this leads to degranulation of the mast cell and release of many mediators. And one of those key mediators is histamine, which will lead to bronchoconstriction, vasodilation, as well as increased vascular permeability, and therefore by giving antihistamines will reduce the level of histamine and help these effects. The antihistamine administered can be diphenhydramine, which is a histamine 1 antagonist, as well as ranitidine, which is a histamine 2 receptor antagonist. Diphenhydramine tends to be more commonly used, and it can be administered IV or orally, and usually a person will be continually on it until their symptoms will subside. Ranitidine is not used as much, however it can be administered IV, and it can have additive effects with diphenhydramine. Another drug that can be used are beta-2 adrenal receptor antagonists, which will help the wheezing patients. And examples of those are salbutamol and salmeterol. In a later video lecture, we'll specifically focus on drugs that are used for asthma. This drug here is not a substitute for epinephrine, but it will help with the symptoms. Now, once anaphylactic shock proceeds, About 8 to 72 hours after the initial severe symptoms, you'll also get a lag or a late phase, which is markedly inflammatory and is mediated by things such as echinocioids and cytokines. Drug administered for that is corticosteroids. And when we spoke about corticosteroids, we talked about them reducing cytokines and also inhibiting COX-2 as well as phospholipase A2, and therefore by administering it we will help to decrease this and hopefully help to decrease inflammation. They must be administered early, however, and can you remember the reason why? I hope you said the reason why is because they act intracellularly. More specifically, they act at a DNA level, which leads to transcription and translation of genes, and therefore their action takes roughly 4 to 6 hours in order to take place. And so they must be administered early in order for this second phase to be inhibited in time. An example of a drug administered is methylprednisolone, which is administered intravenously at a high dose.